Dr. Aruna and Dr. Mahesh. What a privilege. Thank you very much. And what an achievement. 20. Wow. And more than 1,000 participants. It's not a small achievement, Mahesh. And I dedicate my talk to my beloved friend, Vijayalakshmi. An exceptional human being, very knowledgeable, very loving, a great human being. And I particularly thank Aruna and Mahesh to give this oration in her memory. I am an anesthetist. I am proud to be an anesthetist. I am proud to be an anesthetist because anesthetists take away such a lot of suffering from human beings. And that generally gets contained into a short period of time, and practically the same objective and the same experience, the same knowledge of pharmacology and therapeutics, all could be used to spread that relief from suffering over a large period of a human being's life, and that is palliative care. I am going to talk briefly about how these two are integrated. No need to remind this. We are not only anesthetists, we are also primarily doctors. And what is the objective of a doctor? This 14th century aphorism said, "It is to cure sometimes, to relieve often, and to comfort always." And the Indian Council of Medical Research, which organized a task force in the year 2017, which eventually published its report in 2018, specifically on end-of-life care. Its objective was to create a lot of confusion in the use of words like withdrawal of life support in the context of futility being called passive euthanasia, which is an absurd phrase to use. So they created this document, which you can access on the internet for free download, or you can buy one from ICMR. And they remind us that there are no exceptions to this principle. There are no exceptions, including the practice of anesthesiology. Our duty is not only to cure and relieve pain, but also to comfort the human being. And in that process, particularly pain relief becomes very important, not only in surgical anesthesia. Many of you will be critical care physicians, and hence this is valid to most of us. I know most of you would be providing pain relief anyway. Maybe not in the smaller hospitals. I doubt whether a lot of pain relief actually happens in the government hospitals. I would also like to remind you that the bulk of surgical work happens not in institutions like this. They happen out there in the smaller hospitals. How much of pain relief do people get? Even when we are providing pain relief to a large extent, it's by the use of an epidural catheter inserted there for an average of 24 to 48 hours. There is always a pressure to take the patient out of the intensive care unit because more would be coming in. There is pressure on beds. So the patient gets moved out from the ICU and their pain relief stops. But are you feeling that the worst is over? Not necessarily. This is somebody who told me personally. I wouldn't name him. He may not like to cast aspersions on his colleagues. But this professor of anesthesiology says, following cardiac surgery, once the epidural catheter came out, the pain was terrible. And it has its consequence not only on the suffering but also on the physical well-being. He could no longer cough. And the colleagues would laugh. They would not offer pain relief. Why? What were they afraid of? They were afraid of several things, including many superstitious beliefs about opioids. I am making this statement, which I hope is wrong. I hope I am completely wrong. I am saying that the majority of us do not learn enough about pain management. I know many of you will go and do courses on interventional pain management. But look at the website of International Association for Study of Pain. What do they recommend? They recommend that pain management should be multimodal. Concentrating only on technology and concentrating only on nerve blocks is a mistake that I made. For many years, I was an anesthetist who could see only nerves. If a human being comes into my presence, I am looking at the person in pain with a view to which nerve I could block. I actually gave a very successful mandibular neurolysis. Who would do it in these days? This was in the 1980s to a college professor. It was blind. There was no imaging in those days. But somehow it worked. The next day, the man was pain-free. I was very happy. Couldn't stop myself congratulating myself. He asked me, when should I come again? I said, you don't have to come back unless there is pain. This block will last for several months. But if the disease grows to the other side and causes pain, then come back to me. The man went home and committed suicide that night. My block was successful. I killed the man. The oncologist had told him, hereafter your treatment will be there. The man came to me. He asked me, when should I come again? I tell him, don't come back. And then he knew. He went and told his wife, my life is finished. And when she woke up, he was gone. If I had seen anything beyond a mandibular nerve, if I had seen his face, if I had asked one question about what he felt, maybe the wife would not have been widowed in such a traumatic fashion, and maybe the children could have had their dad for 2 more years. Well, he gave up his life to teach me a lesson which I would like to share with you. Human beings are not only made of organs. You do not have any monitor. When I come to you for treatment, someday it is likely to happen. I hope one of you will be treating me. One of you is likely to treat me because I have only 10% chance of dying a sudden death. Like you. 90% of us will go through, or at least 85% of us will go through a prolonged period of maybe bedridden state before we go. At that time, you will use all your monitors on me to find out how the liver functions and how much of blood the heart is putting out every stroke. But do you have a monitor which can measure my fears, my anxieties, my question in me? How am I going to die? Will the pain be even bad? Will I die without taking another breath of air? I may have the same questions when you come and look at me for pre-anesthetic checkup. We do not take pain seriously in this country. We have a philosophical attitude to pain. We laugh at it so long as it is somebody else's pain. So what am I saying? I am saying that you would have a protocol for so many procedures. Let us have one for proper relief of pain. Let us have a study in our own departments about the pain following the 24 hours of epidural catheterization and how effectively it is managed, how much of suffering it is caused. And I believe it would be a great advance if in the patient's chart the nurse makes a mention of how much pain there is. I know that's a dreadful slide. My intention is only to show that such a ladder has been proposed from your city of Boston. It comes from ICRC. What they recommend is a reverse kind of WHO ladder, where in the first step you have morphine and other fentanyl and other step 3 opioids. You have paracetamol, may consider buprenorphine. In the second step, you go down to another opioid, unless there is a contraindication, like tramadol, continuing the other medicines. And in the third step, you take away the opioid and continue only the paracetamol or other NSAIDs. But all this along with any interventional pain management measure that you will continue. And that is continued as long as possible. Maybe along with all our protocols for high-tech management of organs, we need to have this for pain management also. But when we use them, I said pain is not taken seriously. And why I say that is not only because pain is not treated, because of very unscientific and haphazard use of NSAIDs. By the way, do you know what's the commonest cause of chronic renal failure in our country? Well, it starts as acute renal failure. The commonest is iatrogenic. That's not a very complimentary statement for medical profession, is it? Iatrogenic renal failures occur more commonly than any other, and among the various drugs that cause renal failure, the most important, the commonest are NSAIDs. They are used so indiscriminately, over the counter they are bought, and because we do not use opioids properly, the patient has nothing left, so you give him a diclofenac, he swallows 5 in desperate effort to treat pain. And this is such a common problem, but too simple a problem. Doesn't have a high-tech solution, so we ignore it. And particularly, please remember, whatever the medical representatives say, COX-2 selective drugs do not protect against renal damage. COX-2 selective drugs, your Rofecoxib, can be as damaging to the kidney as any other non-steroidal anti-inflammatory drug. And something that came up recently, I think it's very important for us to realize this. Fosbol et al. Published this study in 2010. Why I mention that study particularly is because it's such a huge study. The whole population of Denmark was included. Out of electronic medical records over a 10-year period, they found, what is your favorite NSAID? They found that diclofenac had as much chance of increasing cardiovascular and cerebral mortality, morbidity and mortality as any other NSAID, including Rofecoxib, which has been withdrawn. Has it changed practice? Certainly it has in our institution. In 2011, we stopped using diclofenac. In that study, they found that the safest were Ibuprofen limited to 400 milligram 3 times a day, or Naproxen limited to 500 milligrams twice daily. Because if that dose is exceeded, the person has a 5 times greater chance of getting a stroke or a heart attack. Time to change your practice, not only to patients, also when you give a tablet to your grandmother with osteoarthritis. I assure you, I do not have any shares in any company making ibuprofen. Based on this recommendation, well, after all, you may say it's only one study. It's not. It has been followed up. There are many more. And let me mention a couple more. One more very important information. Even a single dose NSAID carries a much graver risk in the presence of respiratory infection. And The even worse combination is a combination of parenteral non-steroidal inflammatory drugs in the context of respiratory infection. See, about 5 times more of chance of heart attack. And very recently, this study came only a few months back in the British Medical Journal. Again, I mention this study because it's not a small study. This came out of 252 clinical trials which followed upon the 2010 study. And they found that diclofenac has a clear risk of causing cerebral and cardiovascular morbidity. Certainly, we have more than enough reason to abandon diclofenac, but not only that, but also to make use of non-steroidal anti-inflammatory drugs rational, like limiting it to 400 milligrams of ibuprofen 3 times a day and avoiding it in any situation which can be associated with hyponatremia. In our unit, we ordinarily do not use any NSAID other than paracetamol, but sometimes we have to. In someone whose joint pains cannot be relieved by any other means, or cancer pain desperately needs it. Particularly before I move on to another area, let me mention the relevance of opioids. We don't use them enough in this country. We grow poppy in MP, UP and Rajasthan. We make opium in our government factories, export it to the West in shiploads and deny it to our own people. But we have a dual responsibility. True, it can cause suffering. And look at what has happened in the United States of America and in Canada with tens of thousands of people dying every year due to opioid overdose. Only a small part of it is medical opioids. There is much more, but there is a significant part of medical opioids in that abuse. We cannot allow that to happen, and we need that balance, proper checks and balances. But we have also shown in this country that it can be done. How poor is our pain control? Our per capita morphine consumption will tell the story. As I said, we are not taking the example of USA or Canada, but we are taking the example of UK or other Western European countries which seem to have achieved that balance and kept it there for many decades. They treat pain. They effectively prevent major non-medical use. UK uses 241 milligrams, this was 2014 figures, used 241 milligrams per capita. The global average is 6.27, and look where India is, 0.11. What does it tell us? You and I, we anesthetists who are taking the lead in pain management, are grossly negligent in what we should be doing to relieve people's pain. We don't use it at all. And even today, the consumption in the country is only about 300 plus kilograms, which should be, if everybody's pain was relieved, it would be something like 30,000 kilograms. Instead, we use expensive modalities of treatment. Look at that figure on the screen. Ours is a noble profession. We are supposed to take away suffering. This study came out last year in the British Medical Journal, published by 3 Indian authors. Just in 1 year, dear doctors, you and I, our medical system, is destroying 55 million human lives by catastrophic health expenditure. Every time we choose to buy an expensive, new fancy agent and inflict the cost on the patient, possibly we are destroying a whole family. And remember, this is growing. If you ask, is it only in India? No. Catastrophic health expenditure is growing all over the world. True. But the World Bank has named India and Bangladesh as the worst countries where catastrophic health expenditure is worst. Today, smaller hospitals are closing down all over the country. The bigger hospitals are growing, and that's where we work more than anywhere else. And generally, this phenomenon is causing great poverty. What is health? Health is not only absence of disease, it's also physical, social, and mental well-being. We should be not only taking care of the surgery and the organ function, not only give pain relief, but our care, our medical system has to be humane. That abominable figure is a disgrace on our medical system. Even yesterday, you were talking about the attack on doctors, which is growing phenomenon in the last 2 years particularly. It happens more and more. If 55 million Indians are pushed below poverty line in a single year, where is all that wealth going? The wealth that was with 55 million people, where is it all going? A tiny part of it comes to you and I, the doctors. The rest disappear into a huge system which is invisible. They are not visible, you are visible, so the doctor gets beaten up. And because we have a responsibility to decide how the health system should run, because we are health professionals, this needs thought. But when I talk about humane care, I am not only talking about the cost. This study by the Economist Intelligence Unit in 2015 compared the quality of end-of-life care in 80 countries. 80. We came among the worst 15 countries. The next day, Times of India carried a news with a banner, "Don't die in India, it is not safe." Because we will inflict suffering at that time and we will destroy that family. Whether or not the patient has a salvageable condition. We do not treat pain or other suffering in end of life, but we inflict suffering by inappropriate intensive care. Tomorrow my time will come. My time is likely to come much quicker than almost every one of you, just simply because I am possibly the oldest in the group. And I know what's likely to happen to my family when I go. Yesterday, two kind doctors, Dr. Shravan and Dr. Rajat, picked me up, brought me to the hotel. We had a half an hour drive or more, but most of the time was taken by a series of phone calls. I got this call yesterday from somebody in Delhi. Her aunt with advanced dementia and advanced Parkinsonism, who has been living a horrible life for more than 15 years, eventually was so agitated that she bit her own lip. With her teeth, she brought out a piece of her lower lip. Possibly that got aspirated. Certainly a lot of blood was aspirated. She was taken to hospital by the loving family. She has been on ventilator for 2 weeks now. Somebody with advanced dementia and Parkinsonism. What is the objective of that intensive care? It is just to prolong her suffering for some longer period of time. We said our duty is to cure sometimes, relieve often, and comfort always. Are we relieving suffering or are we prolonging suffering and destroying the family too? She sent me a series of questions. They are asking for a tracheostomy to be done. They are asking for consent. Will it help? Can we take her home and disconnect the ventilator? What right do we have, the family has? What's your answer, ladies and gentlemen? I see myself in that woman's place tomorrow, and I am scared. I am not scared of death. I know I will die someday. I am quite prepared to accept it. But I am afraid of the dying process in the hands of the medical profession. Sorry. The principle of Bola, which was proposed from the UK first, says that a doctor's duty of care to the patient comes first. And then that is an ethical principle, and a law which does not respect ethics is absurd, causes suffering. This is how we define health, right? Not only absence of disease, but also physical, social, and mental well-being. What are we doing to the 82-year-old woman in a famous Delhi hospital today? Don't we tie up patients in this country? Physical restraint is so common that people live with pressure sores in the back and larger wounds on their psyche, and we do not treat delirium. Many intensive care units use benzodiazepines as a first-line drug for delirium, which is known to cause worsening in the delirium. For a manipulation of circulation, we will have evidence-based practice. But pain does not matter, delirium does not matter, we don't follow evidence there. In a woman like that, even if by chance somebody went on ventilator, we have these papers which show that in the US and Europe, withholding or withdrawing of artificial life support preceded up to 90% of deaths in the critical care units. They can withhold life support when inappropriate, they can withdraw it. But in our poor country, we cannot. Only 22%. That is from the Indian Journal of Critical Care Medicine. We need to think seriously about it. It's easy to say that the families want everything to go on. But how effective counseling do we give to the family? In one of the hospitals that we worked in, we had a series of transfers like this. Naturally, from the critical care unit, patient would be shifted to a high dependency unit. But next to that was a palliative care unit, where the family is not abandoned. Nobody says there is nothing more we can do, because we fully believe there is always something that we can do. If not to improve the serum sodium, to say we care for you and to treat symptoms and to make life to the last moment comfortable, for which we made sure that there was an adequate provision for a counseling room where a medical social worker would be primarily in charge, but the concerned doctors and nurses would have to come and brief the patient and family. And then the family understands. In the story that I mentioned, the family's own feelings came out, but sometimes they may not spontaneously, and we need to facilitate it. But the legal situation has become a little confounding, particularly with the Supreme Court judgment which came last year in March 2018. On the positive side, it recognizes the validity of an advanced medical directive. Our country does not have a law on this matter. I have signed a document, honestly. I have also shared it with my wife, and she has also prepared one, and we have communicated that to my children, and eventually they agreed to it, that in the context of an incurable disease, or if the likelihood that I can return to a reasonable quality of life is not good, I should not be put on artificial life support measures. I have specifically mentioned even a nasogastric tube. According to the Supreme Court judgment, you, doctor, have a duty to respect my wishes. But, unfortunately, this is the problem when we do not decide on ethical standards and practice it. A law without ethical justification comes in. The Supreme Court judgment also put in some clauses. The advance directive that I have written is no longer valid. It will have to be countersigned by a judicial first-class magistrate. If I go there to countersign, he is always waiting without any other work to countersign my advance directive. How busy would he be? And eventually, when Dr. Aruna finds that the person needs to be withdrawn, life support needs to be withdrawn, she will have to call for a 3-member board of the hospital. Fair enough. A medical board takes a decision. It could happen on the same day. And then my wife will have to go to the district collector. District collector will have to appoint another 3-member board, including the district medical officer. How long will that take? While that horrible endotracheal suction catheter is going into my lungs every half an hour. And then a second medical board has to certify this. Not finished. Then the first-class magistrate has to come to the ICU and see me. And only then Dr. Aruna can withdraw the ventilator. 2018 March, almost a year now, not a single person has been withdrawn through this legally valid process. The only hope for the future is legislation on the matter, which is unlikely to happen now because the current government ends this year, maybe for the future. But I believe we who are responsible for human lives and human health have a responsibility to take this forward and make sure that a realistic, compassionate law is in place. In the UK, again, only a few months back, there is a clear recommendation from the Supreme Court that life support can be removed without any court order if doctors and families agree. But how about it now? What can happen to the woman in there, 82-year-old woman with dementia and Parkinsonism? Well, there has been a lot of discussion about this by a task force appointed by Indian Council of Medical Research. And the legal advice that came here was, if you are sure about what the duty of care is, once you are sure that the patient need not go on ventilator, why do you put the person on ventilator? Or if you believe that it is not necessary to continue the artificial ventilation, that's a medical decision. Discuss it with the family. When there is no conflict, if the family is agreeable, everybody is agreeable, then the legal obligation does not come in. Principle of Bolam applies. So it's for us to decide what is appropriate, discuss it with the family. I know there are challenges. Okay, half a section of the family may have agreed. The son from Dubai will come tomorrow. There may be problems. This is not a solution for all problems. In medicine, that doesn't happen. But a lot of current suffering can be reduced if compassionate end-of-life care is provided. And remember, a good health system has the responsibility to give quality service to all people when and where they need them. So, as your potential patient for tomorrow, here are a few direct requests to you. I don't know which one of you will be looking after me. Please treat my suffering preoperatively, perioperatively, postoperatively. Please learn pain management, a little bit of palliative care. Everybody needs that. The compassionate care, what it involves. Unfortunately, in our country, communication to the patient is not taught. In all Western countries, that takes a major part of medical curriculum. We don't have that. So this is something important. And if before you before you take on that important job in a big hospital, spend a few weeks learning a little bit of pain management and palliative care. Whichever stream of anesthesiology or critical care or any other medical field you are going to, I am sure it will change your life, and therefore it will change your patients' lives. And particularly in the intensive care unit, let us give some attention to making intensive care humane. And let me remind you, let us not underestimate the power of a touch, a smile. Don't be afraid to touch a patient. Don't be afraid to give a smile which conveys to you, I care for you. Because when I am there, if you are like a human machine with a stethoscope hanging there and looking only at the screen, I'll be worried. Whereas if you just hold my hand and tell me, we'll do our best to care for you, I'll be reassured. I don't ask miracles from you, but I do demand compassion and humanity. Thank you very much.